Our case is not an unusual woman. 64-year-old woman presents with a 2.8 centimeter pancreatic mass, but unfortunately the mass is encasing some blood vessels and it makes it locally advanced so it's not resectable. Referred to a tertiary care center where I think most of these folks should be taken care of, and they undergo a laparoscopic look. They do a diagnostic lap on the patient and find that there is no evidence of spread to any other parts of her abdominal cavity. Then they make a decision to go forward with intensive chemotherapy using FOLFIRINOX with a nice response, followed by chemoradiation using capecitabine with radiation. Reassessment shows that the cancer has indeed shrunk, and they do what I think is the right thing to do: go in with an operative approach, explore the patient, successfully remove the cancer, margins negative, sew her back up, and then back to us to decide what to do next. So this is a case of locally advanced pancreas cancer, technically unresectable at the beginning. Chemotherapy, chemoradiation gets the patient to respond and subsequently has a surgery which might be curative. Locally advanced pancreas cancer, we're seeing more and more of it, so not resectable, but not metastatic. And these are a patient that really is a challenge for us because we want to try and cure them if we can. Typically, locally advanced pancreas cancer is fatal, unresectable, metastatic eventually. We try chemotherapy, we try local approaches. The fact that we have new medicines that can shrink the cancer and possibly convert them to resectable is a new area for us. A patient who presents with locally advanced pancreas cancer should at least have very good imaging. We argue that something like endoscopic ultrasound, if your center is very good at that, MRI. I think it's not standard to do a laparoscopic look on a patient like this, but it is not wrong to do that if in fact your overall goal is a surgical approach. You want to rule out peritoneal disease if you can before thinking about doing a surgical resection. So you need all of that really good imaging to define where the cancer is, where it isn't, before embarking. Pancreas cancer is also a challenge in that we rarely get enough tissue to do broad molecular testing. When we are lucky enough to do that, I think every pancreas cancer patient should be tested for microsatellite instability, should be tested for BRCA, because we have new data around PARP inhibitors in those folks who have homologous repair deficiency. And if you have enough, it's probably worth doing broad molecular profiling. The world of molecular profiling's really evolved over the last couple of years, frankly. It was considered researchy at the beginning of the story, and so there was a lot of trouble getting those reimbursed. If you requested it, you weren't getting reimbursed. What we've seen now is an evolution. We sort of won the fight, in my opinion, to where now broad molecular profiling is increasingly being covered. New FDA approvals, acceptance that we need all of that genetic testing to optimize our therapeutic recommendations. So fewer barriers to approval and to payment when doing molecular profiling in all cancers.